just going back and looking at, we just talked about your veal chop, but just kind of another overview of that. So it's a good little diagram to show you where you should see good acceleration, to let you know there's good fetal well-being and the heart rate's good. Abrupt decrease from heart rate from baseline would be considered a variable, meaning abrupt, like it's deep and it looks more like a V. And the bottom of it is what we refer to as nadir, but just for y'all's purposes, knowing that variable deceleration usually means cord compression. So we'll do all of our interventions, and a lot of times if those aren't effective and the doctor's concerned about the mom not having enough fluid on board anymore, he'll do something called an amnio infusion. Late decelerations, bad sign, right? So late meaning, where does it fall? It's falling, onset occurs at the peak of the contraction, goes down, heart rate takes a little while to come back up, but it's falling right here instead of your earlies being right on top. Okay, so that just goes over what a BPP is, which is what I've already talked about. I just want you to know what an ideal score looks like, and that the BPP is something that we order, the doctor orders when the NST doesn't look good. Okay, so if our NST is just got, little baby's just kind of flatline, probably because they're sleeping, maybe mom hadn't eaten much today, we'll do a BPP. Now, if the baby's truly in distress, that BPP is not gonna be, it's not gonna be a high score. So if we don't have an ideal score from the BPP, then the doctor will evaluate and say, well, maybe we need to go ahead and induce mom. Or maybe we can't induce mom because it would not be good for her, so we're gonna have to do a C-section. So sometimes this means we'll have to deliver early. And then this goes back to your stages of labor, just kind of breaks it down with that little picmonic there. All right, let's talk about pain management real quick. I know y'all talked about this last semester, but I do want to go over what tends to happen most frequently with our epidurals. So epidural is kind of the pain management of choice with labor, right? So if mom decides that she wants an epidural, she'll discuss that with the anesthesiologist, hopefully early in the labor process and not when she's about to deliver, so they can have a good conversation and decide, is this the right type of pain management for me? If it is, then the patient will be obviously more confined to the bed, but they'll have an actual catheter inserted by the anesthesiologist, and it'll be a continuous drip going into that, okay? Going into that epidural space. Now, what we do as labor nurses is we're going to bolus our mom with at least 1 to 2 liters of fluid, usually LR, before we start this process of the anesthesiologist doing the epidural. Because what is the most common side effect? Hypotension, maternal hypotension. So let's say you have a mom that has just received her epidural, it's just started infusing, and you notice that the next blood pressure, let's say it's been 110s over 70s, and now all of a sudden it's 80s over 50s. What are we gonna do about it?
Ephedrine.
We can do ephedrine. If it's not such an abrupt decrease or a large amount, then they may just do some fluid bolus, okay? But if that's not effective, or obviously if you get an extreme change, like say your blood pressure is 110 over 70, the epidural starts going in and all of a sudden it's 60s over 30s, with some ephedrine for sure, right? You can have multiple doses, anesthesiologist needs to be notified, but they'll go ahead and usually have that ready to go. Other options are just having an IV line and having something called Stadol. There's a generic name for that, Nalbuphine or whatever. But Stadol is a pretty strong narcotic as well. So what you need to know about that is, let's say your mom is getting close to delivery, she's hurting really bad. You go in and you check her and she's 10 centimeters or 9 centimeters. She's like, I gotta have something. If you give her a dose of Stadol and then she delivers within 30 minutes, you may have to resuscitate that baby, okay? So considering that, it may not be a good option to do that, and you may have to be the bad guy and say, I'm so sorry, Mom, I can't give you anything right now. because the doctor may say no. Other option, we might could give her some nitrous. Y'all know when you go to the dentist, you get the fun gas, and it doesn't do much, but it makes you feel a little loopy and you're not really thinking about what's going on. It was actually used years ago, like in the 50s and 60s for labor management for pain, and then it's recently been brought back, and then I saw it go away again during COVID because the aerosolization of everything, they didn't want it. But now it's come back again. So the nice thing about nitrous is it's quick to metabolize, right? It's not gonna go to the baby or harm the baby in any way. It's just gonna help the mom relax. Hopefully when she's getting those really, really bad contractions, she can take a couple of hits of that nitrous and feel a little bit better. The times that I've seen it used, the mom's still screaming the whole time the baby's coming out. But she's just screaming and hitting the gas. So I don't know how effective it is. I think it depends on how you deal with pain. We know pain's subjective, right? So what one person can tolerate, I wouldn't be able to. But I'm a redhead, so we're wimps. So non-pharmacological pain management. Another thing is natural labor. She can just say, I don't want anything. I'm gonna play my music, have my essential oils, maybe get in the shower, maybe do a water birth if your hospital's set up for that. The hospital at EAMC is not, but there are some really nice places in bigger cities that have like birthing centers that do that. But they also have to have the equipment and the capability to monitor with water births. So breathing, that would be like your Lamaze breathing. You know, sometimes when baby gets close to delivering, doctor may not be able to be found quickly, right? So what you've probably noticed if you've been to some labor and delivery clinicals is sometimes the labor nurse ends up delivering, right? So you don't realize how much autonomy they have and how much they're really doing, because they're not calling doc for delivery until it's really time to catch, right? So a lot of times what you may see is when they labor down and get to that point where they're about to deliver and they've called the doctor and they're like, well, I'm gonna be a minute, they may have to put a little pressure back, put their hand, gloved hand obviously, on the baby's head. Do not push the baby's head back in. You're just holding it so it doesn't deliver so fast. Just a little bit of gentle pressure there. Because if it delivers too fast, what's gonna happen? We're gonna tear. So we wanna try not to tear, okay? Sometimes we tear anyway, and that's okay. It's actually, research shows us that tearing naturally is much better than doing an episiotomy, and there are some docs that don't really even do those anymore. And then there's doctors that are old school and they're still gonna do an episiotomy. There's also emergent situations, for instance, like shoulder dystocia, where episiotomy may be necessary to get the baby out as quick as possible. Guided imagery, y'all know what that is, y'all probably remember learned about it from one time. Like, look over there, or let's think about your favorite place at the beach and all. I mean, some people are really good at that, and I just, you know, if I'm hurting, I really just don't want anybody to talk to me. So it depends on where you go in your mind. You may need to be quiet, you may not need a bunch of people in the room. Just depends on how you handle pain and what you like as far as comfort measures. Majority of the time, what I've noticed in most of the hospitals is the nursing staff and the OBs, they try to accommodate whatever the birth plan is to a certain degree. But if a mom has a very specific birth plan, there may be things they have to discuss, like, well, if this happens, can we do this instead? So you have to be a little bit flexible, and sometimes those are difficult conversations to have, but you wanna approach everything with an open mind, because if you go in there and say, no, you can't do that, no, you can't do that, your patient's gonna shut down, and they're not gonna wanna talk to you. So you need to be as supportive as you possibly can within reason, and just ask them, okay, you said you wanna do this, can you tell me why? And if they have a good reason, then it may be something you can discuss, or you can say, well, hey, if this happens, or all of a sudden the baby's heart rate goes down and we have to proceed with maybe a C-section, or, you know, get the baby out quicker, are you going to be okay with that? So just make sure they understand, and the doctor ultimately is gonna do a lot of this counseling, but you as a labor nurse are gonna be with them majority of the time, so you're gonna be talking to them a lot too. So I'm all about a birth plan if it just, at the end of it, it says healthy mom, healthy baby. So that's all that really matters in the end. There's some different things out there now. Delayed cord clamping is actually researched and has shown that it is beneficial to the baby, particularly your preterm babies, because it helps reduce the risk of neonatal anemia. But it's not that beneficial if you let it just turn white. So there will be some birth plans that you'll see, they'll say, allow the cord to stop pulsating on its own until it turns white. I mean, after it does it, after delayed cord clamping, about 60-90 seconds, that's really all you need to get extra red cells to the baby. So I mean, it just depends on the doctor. These are the things that need to be talked about in those prenatal visits, so that y'all aren't sitting there at the last minute trying to bargain over, well, what can we do and what can we not accommodate? There was one not too long ago where the patient had wrote, she wanted vaginal seeding at delivery if she had to have a C-section. Vaginal seeding just means they take a cotton swab and they put it in your vagina to get the vaginal flora, and then they rub that cotton swab all over your baby, because your baby is not getting to go through the vaginal canal. There is no research to show that that is actually beneficial, that it does anything to help the baby. So the doctor at that point said, no, we're not doing that. You can do whatever you want in the bathroom with your baby or at home, but I'm not doing that. But I will say, they are very open if there's something that's actually been researched, and there's studies that show that it's worth it. All right, so we're gonna talk about some complications during pregnancy. We're gonna start off with hard stuff. I can't possibly go over all of these things, but I will go over as much as I can. Has anybody ever heard of a molar pregnancy? Okay, it's really rare. HESI still likes to test on it, so I'm telling you about it now. It's also, the fancy words are gestational trophoblastic disease. It's not a real pregnancy. When you take a pregnancy test, it will be positive because it's producing the HCG hormone, but what it is this big grape-like cluster of cells that's forming in the uterus, and it's just this abnormal cellular development that's just continuing to reproduce, and so the patient will gain weight, they will look pregnant, they will have a positive pregnancy test, but it actually is associated with a form of cancer called choriocarcinoma. And this, if someone gets a hydidiform molar pregnancy, they're typically gonna be over the age of 40. It is more common with advanced maternal age. So that's all I'm gonna say about that, okay? And did y'all talk about hyperemesis last semester at all?
A little bit.
Okay. So basically with hyperemesis, you know it's going to occur in the early part of the pregnancy. Now, the hope would be that after the 12 to 16 week mark, we would get a little bit better and we would start feeling better and less nauseated and be able to tolerate foods. A lot of times, there are people that experience hyperemesis through their entire pregnancy, which is super miserable, hate that for them, and they may require IV fluids, they may have to go home and have like a PICC line and have people come out and give them fluids. So those people tend to be a lot sicker and they tend to lose weight. So they tend to lose weight. So they really have to be monitored closely to make sure they're not getting too dehydrated. They may be admitted throughout the pregnancy. And they may also have to get TPN, worst case scenario. Some of the things that HESI likes to quiz y'all on about hyperemesis is, how do you tell your patients once they are getting ready to discharge home how they need to eat when they go home? Well, they need to eat 6 small meals a day. They don't need to eat 3 big old meals. They need to stay away from foods that they know are spicy or really fatty that are gonna aggravate their reflux, because it's gonna get worse as the baby grows. And they need to make sure that they're drinking plenty of fluids, but they're probably gonna have to drink fluid in between meals instead of during the meal, so their belly doesn't already get that feeling of being distended and overfull. All right, so let's talk about cardiovascular disease in pregnancy. So if we just think about what y'all learned during perfusion, we can be born with a congenital heart defect, and we will go over those next week. We can get something that's acquired, or we can have ischemic, meaning we've had a heart attack, or we've had some sort of MI or some sort of ischemic attack that's, killed part of the cardiac muscle. Acquired would be like your rheumatic fever. Y'all remember that, what that is? Essentially that happens a lot, and if it does happen, it's pretty rare now, but it happens more in children. But even as they get older, they have to have like prophylactic antibiotics when they're going to the dentist, things like that. So congenital would be, I'm born with this heart defect, but then I'm gonna go on and be able to have children if my cardiologist is on board with it, and if I'm able to carry baby to term. So we put it in different classes. So it's New York that does this classification, so the NYHA. So class 1, class 2, class 3, class 4. The main thing I want y'all to know is class 1 and 2 are gonna be the least risky pregnancies, but class 3 and 4 are gonna be our really, really high risk patients. Now, all of these patients are probably going to have to be monitored with the cardiologist along with their OBGYN, okay? So if you have class 1, you're typically asymptomatic when you do physical activity. We don't have to give you any sort of limitations. Class 2 would be asymptomatic at rest, maybe a little limited during physical activity where you do get some shortness of breath. So you can get a little bit of fatigue, shortness of breath, palpitations with activity, but you're still asymptomatic at rest. Class 3 would be symptomatic at rest and with activity, so you're a little more compromised. And then class 4 would be inability to perform any physical activity without symptoms. These patients typically have severe cardiac insufficiency, and they're very compromised. So they're probably on several medications to help prevent cardiac decompensation, and they may even be advised to not have children. But we all know that when we're advised to not do something, sometimes we do it anyway, right? So then when we do that, we still wanna make sure we educate, take care of these patients, and make sure they understand how risky their condition is and how closely they need to be monitored. They can't miss any appointments, okay? So they need to be followed closely. Typically, your class 3 and class 4, they're not gonna want them to have a vaginal delivery, because what happens when you push is all this excess blood volume is pushed towards the uterus and the central part of the body, pushed away from the heart, and so that can lead to decompensation really quickly. So those patients in class 3 and class 4, they're gonna say, let's go ahead and schedule your C-section at however many weeks, 38 weeks, 39 weeks, whenever your term and baby looks good. Class 1 and 2, they may still allow them to deliver vaginally and push. The point is to advocate for your patient, make sure that this is getting passed along in report and that sort of thing, so you make sure that the physician's aware, because we all know after talking with patients, even in 4th semester, y'all know this, they don't tell the doctors a lot of things, but for some reason they like to spill their guts to us or whoever else walks in the room. And so things may not be in the chart that need to be in the chart too, so make sure you're talking to your patients. So usually the ones with cardiovascular disease in pregnancy, they're much higher risk to develop congestive heart failure in the postpartum period. They can develop postpartum cardiomyopathy, and they can get into fluid volume overload really quickly. So those patients, we're not gonna be dumping fluid on them like we would a normal, healthy, pregnant person. Probably gonna be keeping that a little bit, low. Like, we're not gonna be just being like, let's go ahead and bolus those 2 liters before she gets the epidural. She may have to have less than that. And those that are born with congenital heart defects, depending on how bad the defect is and if they've had surgical treatment, they can go on to have babies. My sister-in-law was born with pulmonary atresia, and she's had 2 kids. It was a little scary the whole time she was pregnant, But the thing that scared me the most is when she went in to have the first baby and the OBGYN was gonna let her be induced, and when the cardiologist got there, they were like, absolutely not. She has to have a C-section. Why are we even discussing this? Because her heart was more boot-shaped and she was born with a cyanotic heart defect. There was no need for her to be pushing. She already had an artificial valve and was going to need another one once these kids got a little bit bigger. So that's why it's so important that we collaborate with our other docs. All right, so the way we manage it is really similar to a patient, like when y'all learned about when y'all were going over perfusion that has cardiovascular disease. So we're gonna limit their activity, they're gonna have more frequent prenatal visits, we're gonna avoid excessive weight gain. So how much is normal weight gain with pregnancy? What do we usually recommend? Like 25 to 35 pounds if we have a normal BMI. If our BMI is already high and we're considered obese or morbidly obese, we're gonna keep it around 15 to 20. And the same thing would apply in cardiovascular disease. We're probably gonna ask that they not gain 25 to 35, it's gonna be lower than that. Prevention of anemia, so they need to really stay on top of taking iron. A lot of patients don't like to take iron, not just pregnant patients, but in general, what does iron do?
Upset your stomach.
Yes, it can cause nausea and constipation, right? But iron is necessary for those red cells to be able to carry enough oxygen to the rest of the body, so we need the iron. So really important to stay on top of the iron supplements and then monitor for signs and symptoms of decompensation. What's a sign and symptom of decompensation with cardiovascular issues? What do you typically see when they start declining? Just in a normal patient, not even pregnant. Shortness of breath, what else? Edema. And then they get a wet cough, right? So you're gonna see these similar things in these patients that have cardiovascular disease in pregnancy. So intrapartum, we're gonna manage it by inducing labor. Typically, it's gonna be a little early, but it's probably gonna be at least close to 37 weeks. 37 weeks is considered term, 37 and 0. Anything before that is considered preterm. So administer oxygen as needed, prophylactic antibiotics, pain management, and minimize pushing. Remember, because I said if you're in that class 3 or 4 category, a lot of times you can't push at all because of the amount of blood that goes into the uterus with pushing. When we minimize pushing too, the ones that we do let push, we're not gonna let mom get to the point where she's been pushing over 2 hours. She's been pushing for about an hour, we're gonna do some other things, get the vacuum out. You typically do not see forceps being used at all anymore. It's typically gonna be a vacuum, and then if it looks like it's gonna be even more prolonged and mom is super exhausted and we still can't get baby out, we'll go for a C-section. All right, so postpartum, again, we'll monitor for signs and symptoms of decompensation, closely monitor INO, aggressive diuresis. So a normal patient that doesn't have cardiovascular disease, when they have their baby, their body does this huge hormonal shift, and they'll also start diuresing off all of that fluid they retained during pregnancy, plus all the IV fluids we dumped on them. So what you'll typically see is they will be peeing like crazy, but it's not the, you know, when you get to the end of the pregnancy and you're getting up and peeing every 5 minutes, but you're only peeing about that much. You're peeing a lot larger amount now because you're actually able to empty your bladder. You don't have the fetus putting all the pressure there. So monitor vital signs, include pulse oximetry so we make sure we're not declining there. And then your medications, these are all medications that can be taken in pregnancy if needed, depending on the severity of the symptoms. So same rules apply as far as Lasix. What do we need to know before we give it? Potassium level, and then our blood pressure, right? What about digoxin? Heart rate. So what if the heart rate's 50?
No.
No, we're not gonna give it. We're gonna let the doctor know. Nitrates, usually if they start having some angina or a little chest pain, we can give those if needed, but we're gonna watch blood pressure closely there as well. Your beta blockers, like your labetalol, remember your LOLs, those are most commonly used in pregnant patients because they're one of the safer antihypertensives, along with your calcium channel blockers like nifedipine. Now, you will not see them using ACE inhibitors or ARBs or anything like that in pregnancy because they carry severe warnings for pregnancy. So typically they're a no-no because there's so many congenital defects that can occur with them that are not compatible with life, essentially. So you're not gonna be on anything like that, but beta blockers and calcium channel blockers are safe. And that drug table that I made for y'all has those on there, which ones they're using. And antibiotics, obviously prophylactically, to protect the heart from endocarditis. And then aspirin is commonly given to these women, baby aspirin, all throughout the pregnancy. And then they may also put them on Lovenox or heparin, depending on how severe their symptoms are. All right, so what's your role? You're to assess, monitor for early signs of decompensation so you can notify the physician, hopefully get some treatment on board if mom isn't already taking any medications, prevent complications, education, making sure they understand the importance of taking their medications, because a lot of times when women are pregnant, they're really scared to take stuff, right? They don't know if it's safe. And these days, we just, don't know if anything's safe because it's all over the news that we can't take Tylenol, right? So as far as I know, acetaminophen is still safe in pregnancy until your doctor says otherwise. So my opinion on that is discuss with your physician, someone that is a medical professional, because there's going to be research as the years go on. But if you think about how long did it take for them to take Zantac off the market? It took many, many years. So I'm not saying that down the road we might realize maybe Tylenol wasn't the best thing. But when we have all these studies out there about Tylenol and pregnancy, it's because all we're ever allowing women to take when they're pregnant is Tylenol. So of course you're gonna have correlation there, right? Correlation doesn't necessarily mean causation. My kid's autistic because of my father-in-law. If you met him, you'd be like, there it is. That's exactly why. So there's multiple reasons for things. So don't just if a patient brings that up, don't argue with them. Just say, I understand your concern, because the concerns are valid. We instill fear into people when we just announce things on the news, okay? Without, how much fear did we all have when COVID happened? None of us knew anything, and most of us that were working in the hospital were scared to death, right? Including myself. So just make sure that you don't dismiss their concerns, but make sure if they have concerns that you're talking to them, and if they need to talk to the physician, have them go in and talk to them. Just don't be judgmental. All right, hypertensive disorders in pregnancy. So what we know today is a lot of us don't go to the doctor regularly, right? Not everybody's big on getting that annual physical where they check your blood pressure and your cholesterol and tell you need to eat better and that your blood pressure's high. So a lot of times what we see is women that either were previously diagnosed with hypertension or they developed it during pregnancy. So if they have already been diagnosed with it before pregnancy or they have it before 20 weeks, it's considered chronic, okay? It is not considered gestational. If it develops after 20 weeks, then it's considered gestational. So I like this little algorithm here, flow chart. It kind of shows you. So less than 20 weeks, gestational for diagnosed. So let's say you have a patient that comes in and they just found out they're pregnant and they're 8 weeks and their blood pressure is 150/90. That's probably chronic hypertension. But it still needs to be taken on 2 separate occasions, at least 4 hours apart, to be diagnosed as hypertension. If it's after 20 weeks, same thing. If they come in for that first visit, or, sorry, not the first visit, if they come in and they're 24 weeks and their blood pressure has gone up from the last time they were there, and you notice that it's a little bit higher, you wanna check it again after a few hours, to make sure that it is indeed really high, or that it's not, just related to, some people say they have white coat syndrome. Some people very well do get anxious when they go to the doctor, and that's understandable. But some people actually have hypertension and just don't want to admit it. So, preeclampsia, eclampsia, so that develops when you have gestational hypertension plus protein in the urine, or proteinuria. And some of y'all know about this because we talked about this yesterday or last night in Sim Lab. Anything, as far as protein to creatinine ratio, they'll get a little dip of the urine. If it's 0.3 or higher, it's considered diagnostic for preeclampsia. Your Saunders book will tell you that you don't have to have that PC ratio elevated to have preeclampsia. That is absolutely true, but it's rare. They're just trying to make you understand that you can have preeclampsia without the proteinuria. But even if you have preeclampsia without protein in the urine, you usually still have low platelets. You may have liver involvement and elevated liver enzymes. I'm never gonna ask y'all what normal AST and ALT are, okay? Because those aren't common for y'all to know. If I was, gonna give you something like that in a question, I would put it in there, I would say they were elevated, okay? And then eclampsia is an additional complication where we have seizures. So you can develop a grand mal seizure if we're not treating the preeclampsia appropriately, or maybe we are, but we just didn't jump on it soon enough. So gold standard treatment for preeclampsia and eclampsia is magnesium sulfate. And we'll talk about those drugs in a little bit. You can also have, what's even more not fun, is chronic with preeclampsia, which we call superimposed preeclampsia. So these patients are already chronically hypertensive, and then they get to develop preeclampsia on top of that. So that's why they call it superimposed. So these patients are a little sicker. Typically, we're having to monitor them pretty closely. Now, usually if you develop preeclampsia, or your patient has preeclampsia, they're gonna be monitored closely. They may start having them come into the office more frequently or go over to the hospital, especially in that third trimester, and get daily NSTs or weekly NSTs just to make sure everything's looking good with the mom's blood pressure, if she's having any other symptoms, or is, if the baby is also looking like they're doing okay. And the longer we can keep the baby in for development, that would be better. But if mom continues to decline, or she starts having more liver involvement, low platelets, or hemolysis, or anything like that, then it's going to be that we need to deliver her sooner rather than later. Okay. So here's your pathophysiology. I try to simplify it as best I can, but basically it's just like a really bad vasopressor disease. And we didn't know exactly what caused preeclampsia years ago, but we do know that it has something to do now with research with the placental dysfunction. So the way the placenta implants and the way those spiral arteries form, there's some sort of vasoconstriction that's occurring because of the vessel damage that's happening that's causing this vasopressive disease. So that is why we also have headaches, because we have extreme vasoconstriction. These headaches will be so bad sometimes that the patient will complain of blurry vision. They may say they're seeing spots. They may also see like little halos. And we can have something called mild preeclampsia to severe. So mild meaning, mild hypertension, 140s over 90s, maybe having a headache every now and again. But as far as our lab work goes, we're not having a lot of renal or liver involvement at that point. When we get to severe, blood pressures will be 160s over 110s or higher. And you'll definitely see an elevation in their liver enzymes, more leaking of protein across the kidney, so more proteinuria usually. And sometimes you'll see their hematocrit go up initially. So it's normal to be slightly anemic in pregnancy, in a normal pregnancy, but with these patients, preeclamptic patients, a lot of times what you'll see is their H&H will be a little bit higher than normal because of all the vasoconstriction. Okay, so risk factors, there's a lot of things. What we see most of the time, we see it a lot in our first time moms. So first pregnancy, that tends to be when we see it more, but it can happen in any pregnancy. And especially once you have it once, you are at high risk of having it again. Age extreme, so I mean that like anybody less than 17 and anybody over 35, because we know that 35 is considered advanced maternal age, even though that is not old. And now it makes me feel old to say that. Yeah, so age extremes. I have noticed just over the years of working that my patients that were really young, that had preeclampsia, they were super sick. And they'd be more likely to seize on me than any of my other patients. They usually scared me a little bit. Diabetes, that's a risk factor for everything, right? Chronic hypertension, multiple gestation, so obviously if you've got twins or triplets in there. Condition called fetal hydrops, we don't talk a lot about that, but it's basically where if you looked at a picture of a fetus with fetal hydrops, because it's not compatible with life, once they're born, they basically have extreme fluid volume overload and they third space out all their fluid, and so their heart doesn't function, their body's not perfusing, and they typically just look very edematous, but it's fatal for babies. And then the hydatidiform molar pregnancy is a risk factor. History of preeclampsia, immunological factors. So your patients that have like lupus or already immune compromised, like rheumatoid arthritis, things like that, they're at high risk. RH incompatibility, what do I mean by that?
Mom, positive, baby's negative.
Right, so mom will have a negative blood type, baby will have a positive blood type, and even though that maternal fetal circulation is not supposed to mix, there is some mixing that occurs, so that RH incompatibility can also be a higher risk for preeclampsia. African Americans are higher risk for preeclampsia, artificial insemination, and it should say too with that in vitro fertilization. So, because you see a lot more IVF pregnancies now than you do artificial insemination, but either one that are artificial means of maintaining the pregnancy, they're at high risk. All right, so this is just another little picmonic that I like, that it gives you the basic rundown of signs and symptoms, what you'll see, some risk factors that are most commonly seen, and some of the complications that occur. So we talked about lab values. So remember I said H&H can be slightly elevated, so a little bit vasoconstricted. Platelets are low. What's normal platelet count?
150 to 400,000.
Yeah, so 150 to 400,000. So usually when we say low platelets, or what's the other word for low platelets? What's the fancy word? Thrombocytopenia, right? So that's a fancy term for low platelets. It's gonna be less than 100. PCR, or protein to creatinine ratio, so this is just one urine sample that gives us a protein to creatinine ratio. And if that number is 0.3 or higher, and that's in diagnostic for preeclampsia. There's something called a 24-hour urine that we can also do. Y'all probably learned about that back in first semester. How do we collect a 24-hour urine?
Discard the first one.
Discard the first one and then all night, keep the urine on ice, right? What happens if I get up in the middle of the night and I pee and then I flush it?
Gotta start over.
Well, gotta start over. So a lot of times these patients will have to be in the hospital to ensure that we're getting the correct measurements. But a 24-hour urine will just give us an even greater breakdown of the protein to creatinine and also tell us how well our kidneys are functioning. Because usually the patients that are very sick with preeclampsia, they won't put out a ton of urine. And it'll be really, really concentrated with protein, sometimes ketones as well. Liver enzymes, particularly AST and ALT, will be elevated. All right, so maternal and fetal morbidity and mortality. So typically with your moms, issues that they have with preeclampsia after the fact or during is renal failure. So a lot of them can go into acute renal failure. So remember how I said normally after you have the baby, you diurese all that fluid off, so you're just peeing like crazy. These patients are not. They have minimal urine output. What's normal urine output?
30 mils.
30 mils per hour. So we at least need to have that. Seizures, obviously we go into eclampsia. Pulmonary edema, so that's due to that fluid volume overload. So those patients, you'll listen to their lungs. They'll usually be a little wet sounding, maybe have some crackles in the bases, and they may also develop a wet cough as that gets worse. Cerebral hemorrhage, I just basically mean a stroke there, right? So these patients are, some of the complications they can have is they can actually have a stroke as well. That's why it's so important to educate these patients and make sure they understand, especially after they have a baby. You go home and you're worried about the baby and not yourself, because there's a lot of things that can happen to mom. So if we don't take care of mom, we can't take care of baby. Liver failure, DIC, which we'll talk about that in a little bit. Did y'all talk about DIC and perfusion? Okay, so I usually go over it with this, but I talk about how it's also, you know, you can have DIC in traumas, you can have DIC in sepsis, so it's not necessarily just a pregnancy-related complication. Fetal, so placental abruption occurs more often with preeclampsia and eclampsia. Intrauterine growth restriction. So if you just think about the mom's got high blood pressure, right? And she is, her placenta is not perfusing that well to the baby. So then what's gonna happen to my baby? It's gonna be a little smaller, right? On the plus side, a lot of times with preeclampsia, even though they may be born a little early, their lungs usually do a little bit better because of the stress from the vasoconstriction. Non-reassuring fetal heart rate, and then obviously fetal death, particularly if we have an abruption or anything like that. So screening. So we want to hear from our patients when they come in, how have you been doing? How are things going? If we're seeing them in the hospital or we're seeing them in a clinic setting, we need to be asking them if they're having any of these symptoms. Obviously, when they come in for a prenatal visit, we're gonna get a weight on them, so we're gonna know how much weight they gain from one visit to the next. But when y'all talked about perfusion, did y'all talk about how much weight gain was too much? Like if you're in fluid volume overload?
2 pounds a day.
Mm-hmm. Yeah. So usually like you shouldn't be gaining more than 2 pounds. What was it in a week? Is that what y'all said in perfusion? Because typically with pregnancy, you're gonna gain some weight, but you shouldn't be gaining like 2 pounds in a week. So seeing spots, stomach pain under right breast. Stomach pain under right breast is the term for that is epigastric pain. And what that's referring to is when there starts to be liver involvement. So those liver enzymes get elevated and you may even develop a hematoma on the liver. So that's what epigastric pain is. Edema, it won't just be that your legs and your feet are swollen, because a lot of women have swelling in their legs and feet in normal pregnancy, right? But what we tend to have with preeclampsia is more third spacing of fluid, so our hands and our face are really swollen. And you can see it as it progresses. Increased deep tendon reflexes, so these would be your patella or your brachial reflexes. When you go to check them, what's the normal grade on those? Like what's a normal reflex? +2, okay? But if we get really brisk, or what we call hyperreflexive, +3, +4, or clonus, y'all remember what clonus is? So, if I put my leg up on the table, and then, yeah, so one of you come back and push my foot, and then let it go abruptly, if my foot keeps tapping, that's clonus. That just means I'm in a hyperreflexive state, and I'm at high risk, for seizures. So we shouldn't see clonus unless we're getting really sick. The other thing with the persistent headache, decrease urine output, which leads to the weight gain. And then another thing that is sometimes helpful for y'all to remember, can I erase this?
Yes.
Okay. Called spasm. Y'all can take a 5-minute break and go to the bathroom. I was told y'all didn't like to take breaks, but I'm gonna write this on the board.